The Egyptian Vitreoretinal Society is the oldest society in our region concerned with vitreoretinal surgery. It has been established in 1998, and over the past years we have held so many successful meetings, and our meetings are different in several aspects. First of all, we offer the best scientific level and the strongest scientific content, and we focus on teaching.
We believe that the exchange of knowledge and ideas between different speakers from different parts of the world enhance our knowledge and will enrich our discussions, and we thank you for coming to our meeting. Thank you.
Okay. Good afternoon, my dear friends and colleagues. On behalf of the Egyptian Vitreoretinal Society, I would like to welcome you to our webinar about COVID-19 and its impact on ophthalmic practice across the countries. I would like to thank EVA Pharma for the initiative and support, and RM Solutions for the technical support they always offer our society. We all agree that we are living an extraordinary and unprecedented time, a time in which all what we have taken for granted, like seeing patients, operating, and seeing friends and socializing, which has been taken for granted, is now very exceptional, actually. The impact of this pandemic now in the near future and in the remote future will be enormous, whether on our practice, socially, and politically as well. And that is what we are going to discuss today. I would like to welcome our panelists in alphabetical order. Each one of them is an icon in his country and in the region, as well as internationally. So we have Professor Barbara Parolini from Italy, Professor Şengül Öztürk from Turkey, Professor Sherif Sheta from Cairo, Egypt, and Tariq Sha'rawi, Professor Tariq Sha'rawi from Geneva, Switzerland. Briefly, we are going to discuss the following topics, and I'm going to show you to you in a very brief presentation what we are going to cover. Each speaker will go through the current status of COVID-19 in his country, the safety measures he's taking for staff and patients, is his practice open or closed, the financial implications, and what does the future hold, and what is our recovery plan. If the practice is closed, he's going to explain the steps taken to close the practice, whether he's forced or elective, any financial support, handling staff and patients, effects and impact of this decision on the future. How does he handle emergencies? Which patients to select as an emergency case? How will he operate him, and what are the extra precautions he is taking? And if he's testing his patients for COVID-19 prior to surgery, and the financial implications we are all worried about. How are we managing the payroll and staff, decrease the fixed expenses and bills, and increase our financial liquidity? Are there any benefits from our governments, and how are we going to prepare our inventory for reopen with presence of deficient supplies because of the lack of transport across the countries as we see? And finally, I'm going to listen to the personal experience of everyone about the daily life, extent of daily quarantine and curfew imposed, and interaction with patients of COVID-19's positively tested patients as well. So this is briefly, I would like to invite Professor Barbara Parolini to present her talk. Barbara, please.
Yes, I'm here. Can you see my screen?
Can you share your slides? Yes.
Yes, we can see yours.
It's working, right? Okay. First of all, I would like to thank you. It's such a pleasure to be among friends and colleagues. I feel like I'm an ophthalmologist again, so much silence around. So anyhow, let's talk about the COVID virus this time and how it changes our life. You have to excuse me because I have, let me stop for a second because I have to get rid of one. Okay, let me start again. I could not read my slide.
Okay.
I decided to start telling you what is the current situation in Italy. You hear the news. However, I made these slides 2 days ago, and I spent some time today updating the number because, unfortunately, as you might understand, it changes by the day. So today, the tested positive people in Italy are 83,000. And that people are 13,000, actually almost 14,000. And as you know, some of them are doctors and staff taking care of the patients. it's good to know that the healed people, we have healed people, and we hope they will stay healed, although everybody fear the mutation of the virus and possible new contamination. But let's focus on this number as well.
Barbara, can I stop for a moment, please?
Yeah.
Can you share your slides with us, because we cannot see them on the screen?
You cannot see my file?
Can open it. Yes. Can you share it?
Ah, sorry.
Okay.
Sorry. Let me go back. Okay.
Yes, that's perfect. Thank you.
Sorry. Okay,
No
this
problem.
slide I was and so many people are still in the hospital, or almost 30,000, and in ICU 4,000. So the total number of people involved with the virus are 115,000, more than that. Lombardy is the region with the higher density of sick people. This is the region where I live. Brescia is one of the cities with the highest number of positive people, and that's the city where I work. It seems that there is a sex privilege which is different by age. So young people under 50 years of age, female are more affected than male, but over 50 years of age, male are much more affected than female, and above 80 years of age, male are affected 3 times more. And we know that people who died all had comorbidities, and that does not make any difference by age. So it seems that the people at high risk of dying are people with comorbidities like cardiovascular, respiratory disease, diabetes, cancer, or immunitary deficit. Italy, as you know, is all locked down, although the problem is more confined in the north. But we have cases everywhere, so everybody is asked to remain isolated in the house, and citizens can exit the house. We don't have curfew. We cannot just leave the house at any time. We have to provide an auto certification if the police stop people in the street. You have to prove why you are going out, and it's justified, of course, for health reason, for work when it is a necessary service, and to buy food or to go to the pharmacist, but you have to show the ticket that you have gone to buy something which was necessary for your life. And it's not permitted to assist sick people. This is very sad, very hard. It means a lot. All gatherings are not permitted, and in this moment it's mostly the funerals. So we cannot have funerals for all these dead people. That is the thing that is most painful. As far as ophthalmology in Italy, all the elective procedures are postponed, especially like cataract or refractive, and emergencies like retinal detachment, trauma, intravitreal injection, they are offered only in certain institutions, and mostly the private centers are closed. In my private practice, and as I told you, it is in one of the hot spots, unfortunately, of the COVID area. At the end of February, so at the beginning of the infection, we started to see one patient every 30 minutes, alternating patient in different waiting rooms. Patient staff, myself, were wearing surgical mask and glove. And it's been very hard since the beginning to find the mask with the double filter, but it seems that the surgical masks are enough. And we were disinfecting the instruments after every patient and measuring the pressure either with the pneumotonometer or with single-use cap for the applanation. when IOP was crucial to know the exact amount. We decided to completely close the clinic on March the 2nd, because the numbers in our town and in the north of Italy was raising so fast, and we had some of our patients that called to say, I have been in contact with the sick people, and I don't know how many of you I have touched or contaminated. So even the staff in the clinic just went crazy, and it was the only solution. Although the administration asked me what I wanted to do, but I had no other choices. So we could not just use the previous precautions. We decided to stop. And the patients were self-limiting themselves, just calling to cancel the appointment. So there was no other choice. In this month, in March, I have offered a cellular phone to all the patients. We wrote them many times, and we called them WhatsApp, email, every possible communication way to let them know that they had to be in contact with us for any emergency. So basically, I went to the clinic just myself, and of course, even with no charge, just to see the emergency cases or anything that could not be postponed. It's difficult to give a list of emergencies, but we can decide on the phone what has to be taken care of immediately or not. As professional, the private doctors, we don't have financial support. The staff is at home, and they receive a partial continuous salary, and they keep their position. They know they will keep their position. Fortunately, loans payment for the instrument can be freezed or stopped. I'm still waiting, and we are still waiting for to know from the government if something will be done as far as tax payment. This is crucial, but the banks are helping us with loans for the house, for anything. And it's been 1 month, one full month. So I think that, and you can share with me this thought, most of our eye problems can be postponed for some weeks, not all of them, but not more than that. And so I have receiving calls and messages more and more often from the patients. So we decided to reopen the clinic, just saying we are available in certain days. We will use all the precautions, and we will make triage on the phone, trying, of course, to understand who is a suspect, who has a suspect viral syndrome or a suspect contact, in order to avoid those patients. And fortunately, we have supplies to start again, because we found different sources to find supplies in order to be able to offer surgery, injections, and anything that is necessary. What about my daily life? I spend a lot of time at my computer trying to figure out many things, how to optimize my educational work, prepare talks, courses, and I'm focusing on softwares and trying to be very effective in the shortest time. I spent a lot of time with my family. This is the only good thing about all this crazy time. I'm attending my mother in the hospital, so I'm in the hospital, but as nurse, not as doctors. My husband works in the hospital every day, so there is all this fear about contamination brought to the house due to our need to go there. And of course, I spend more time as mother with my daughters. I want to thank you, because all this time in silence is really confounding. Sometimes I risk to forget who I am, and this meeting is helping me a lot to be with you and to remind me about my life, because you were saying, and many people are saying, that now we understand what's important in life because we take things for granted. I can tell you, I never take things for granted, never. I am used to remember times when I risked life. So I try to live every day since many years as it was the first day of my life. So and I love my life. So I'm grateful for this reunion with you. And of course, we are full of hope for the future. I think we all have to try to learn from the pain and sorrow and try to remember and cherish all the good that comes from this time as well in order to have hope for the next future. Thank you.
Thank you, Barbara, very much for this very nice presentation in a country in which we know has been inflicted hardly by the disease.
Yeah.
And now I would like to go to the panelists, starting with Tariq. Tariq, do you have any questions for Barbara, comments?
More of a comment rather than a question. I'm very touched by what Barbara said. Italy is our southern neighbors. They're very close to us, and Italy is very close to my heart. My honeymoon was in Italy. Barbara, I would just want to ask your opinion about using the new pneumotonometer in measuring intraocular pressure, because the ASCRS had, issued some guidelines asking ophthalmologists to refrain from using air puff tonometers for the potential spread of the virus from the cornea. I don't know your take on that.
Right. It's difficult to know what's the best thing to do because unfortunately sometimes we have to deal with the practical problems. You think about that, we ran out of disinfectant at a certain point. We had no other choices. So I was just telling you not what is the best thing to do, but what we were actually doing. Yes. And because we ran out of masks, we ran out of gloves, we ran out of any disinfectant. It's been, but then we decided to close, so we had time to organize ourselves again. And so, yeah, it might be true that even with the puff, we risk something, but it's less contact. And so if you have enough single use, that's the best way. Of course, it's more precise.
Yes.
Good point, Tariq.
Then you have to balance.
Yes. Dr. Sharif Sheta, do you have any comment?
Yes, I'm happy, Barbara, to see that you are reopening your clinic. And what measures have you taken, you and your staff, to be ready to receive whatever patients you have? Will you go do things differently, or what are you going to do when you are reopening?
Of course, it will not be open as we used to. Again, we have, first of all, to isolate one patient from the other as much as possible. So scheduling the patient will be the major difference. And we will ask patient to come with the mask and the gloves. If they don't have, we will provide. And so this is the main thing, because then we will basically do anything that the patient needs, but with slowly. Slowly. And
in our country, because the number of population is high, and we still see some patients. So what we are going, instead of, besides spacing appointment, that we are different seating areas.
But I can tell you that I'm speaking only about the clinic where I work, which is a private practice. And so if you think about, if we speak about hospital, it's completely different because numbers are different. But people are really still self-limiting themselves a lot.
That's perfect.
Even in the hospital, they don't go as much. So I'm afraid that they are keeping their high problems and for a while more. But, it's been more than 1 month now, so we are expecting things to change. And I think that private clinic outside the hospital should be the main centers, because it's better to keep away from the hospitals this time.
Okay. One last brief comment from Shangul before we share your presentation with us.
Okay. Thank you, Hani. Thank you, Barbara. I watched your presentation, with my heart, actually, because we are all facing almost very similar things in these days in Turkey. And I just want to ask you if you have any COVID patient-free hospitals or eye centers to take care of patients with routine, non-urgent eye problems?
Only some private clinic. Hospitals, no. No, because most of the ophthalmology units in the city, my city, and in the cities all around, they were converted into COVID ward. Okay. So most of the ophthalmology clinics were closed. Just only the university kept working as ophthalmology, just for the emergency.
Okay. Shingul, can you share your presentation for the sake of time so that we move forward?
Okay, I will. Mm-hmm. First of all, I would like to thank you again, my friend Hani, for inviting me to this meeting, because we really missed such meetings, missed to see friends every time we were, together with you, all of you, but for a long time we couldn't meet each other. And I would like to share our perspective from Turkey and the impact on ophthalmology practice, especially retina practice. World has faced lots of pandemics during the history, like plague, which comes back again and again during many centuries, and cholera and smallpox, Spanish flu, HIV still going on, and plague has killed like 30 to 50 million people, which is almost half of the world's population at that time. And then smallpox again has killed almost 90% of population in America continents, which was, during the arrival of Europeans to America. Cholera also started from India, Spanish flu during the First World War, and all of them killed millions of people actually. Now we are faced with coronavirus disease, which is called COVID-19 right now. And it started from Wuhan, as we all know, from China, and now it reached over 1 million patients infected, and the number of deaths is more than 50,000, so it's a lot. And the trend is still increasing all over the world. It started from Wuhan, and I just want to mention about Dr. Li Wenliang, who was the first physician who raised the awareness about the COVID outbreak. He was an ophthalmologist. He alerted doctors through a social media, and he was accused for making false comments on the internet. And unfortunately, he died of COVID-19 at age 33, which was really a very young age. So what's the situation in Turkey? Our first case was announced at 11th of March, and it's been like 3 weeks since then, and our number of cases increased to 18,000, and the number of deaths is 356, at least announced, the known ones. So the steep is very, very steep, as you see here, so we are anxious about this problem. Actually, there are many precautions taken by the government after the first case in social life. The schools were closed just 2 days after the announcement of the first case, which was very early actually as compared to many of the other countries. And most of the shopping centers, football matches, restaurants, many things have been closed just within a week or 10 days after the first case. And there's curfew for people over 65 years of age, and social distancing, stay-at-home messages are given. And there are many transport cautions. All international flights were canceled last week. The borders were closed. Bus services from one city to another were stopped. And new distinct designs for social distancing in public transports were announced. And still, curve is too steep. And Istanbul is the center for that. Like 60% of the cases in Turkey are in Istanbul, unfortunately. So these problems will cause some financial issues, of course. because dismissals will increase unemployment. And this is tried to be decreased by government. Government started to support employers for their employees' salaries during this closure period. And government declared a campaign for donations, and our president started a campaign by donating his 7-month salary as a start, and some politicians also made some donations, and everybody was stimulated for that. And production of masks and other personal protective equipments has been started in factories which were producing some other things previously for donation. Arçelik, which is a very well-known, big household appliance company in Turkey, has started a project and has already produced a prototype of a ventilator, which will be very important for the next days, I'm sure. So what's my approach for pandemic? I stopped all my international travels since the beginning of February, not March, but February. I didn't accept new cases in my private clinic since the 16th of March, so 2 weeks. And I continued my work in my university clinic. But our approach changed according with respect to appointments. We increased the intervals between patient appointments, and we were dealing with more phone calls and interviews with the patients. We emphasize patients with home monitoring and educate what is urgent for their disease. And if they're coming from out of town, we send some medical reports to the patients to get their injections or treatments in their hometown if possible. So patient volume decreased tremendously. And before coming to examination, my secretary asked these questions. If they have any sign of the disease or any contact with any coronavirus infected people, or if they have been in a crowded place with close contact. So if they say yes, their appointment is given after 2 weeks of quarantine. And of course, we have some precautions during examination, like masks and protective shields, goggles, and we try to stay away from patients as much as possible. Social distancing is not possible with our, examination, but you see, we can do some shields. This can be done with acetate papers. It's very easy to do it. I have done it in my biomicroscope, the slit lamp, and I also use goggles and standard surgical masks. But if I feel there's something wrong, any problem with the patient, I use N95 masks. And we can also use some shields like this. These are also very effective. And I just want to show this video to you, but we are trying not to touch the patients if possible, especially for medical retina follow-up cases. We just take the visual acuity, OCT, and color from these pictures, and then just decide to inject or not to inject. And I prefer more indirect ophthalmoscopy, but of course, we can't do retinal examination like this. As you know, we have to use the indirect lenses, of course. We can't do it like this, but I like this video. So I prefer more indirect ophthalmoscopy if I'm not, if I can. And is there any transmission through tears? This is a problem. It's a question. And there is a very recent publication from Singapore, and they have shown that in the COVID-19 positive patients, they couldn't show any viral culture or PCR. They couldn't detect any virus load. So there is a very low risk of ocular transmission with tears probably. But 1 to 3% of patients has pink eye. This is another information. So who to operate? We know that we should operate emergent and urgent surgical indications. We all know these indications like open globe injury, acute endophthalmitis, ROP cases, acute retinal detachments, and all these things. And we all try to postpone macular holes, retain silicone oil, epiretinal membranes, and diabetic vitreous hemorrhage, things like that. And we also accept patients with acute vision loss, painful eye, or early post-op surgical follow-up visits, ROP screening, and some medical retina cases also, like wet ARMD cases, because most of these are having some fixed regular intravitreal injections which cannot tolerate increased internals. We have to do the injections for these eyes. Other non-ARMD related active CNV cases, we also inject, but we try to increase the intervals between the injections with treat and extend regimen. For diabetic cases, I inform them that it's not a big problem if one or two of the injections are skipped, because it usually doesn't give permanent damage. But the best part of this pandemic was, of course, family life for me, as Barbara said, because staying at home, having more time with my family and my daughter, and also my son, and sleeping enough, because I was sleeping just 5 hours a day, but now 8 hours a day, I can say. Having dinner together every day is really a gift at these days. I can do many academic works waiting for me for a long time, and writing papers, and do more sports, and like this together with my family in my home, at my home. It's really nice. But some of our residents has already been charged in COVID clinics, and our curve is too steep. Probably we will be in charge during the upcoming weeks in the hospitals. So we have to do what we have to do. And at the moment, more than 600 medical people are infected in Turkey, and we have already lost some very precious academicians. And because of this, probably, Time has chosen the medical workers as Person of the Year, and we are all clapped by this is with the cost of our lives, actually. I hope it ends by summer, and I'm sure economical collapse will follow after that, and crimes and robberies may increase. I hope not, but the life will not be the same afterwards. I just want to say bye with this video, which shows the best part of.
Thank you for shaking us and showing us we are dependent on something much bigger than we think. Thank you for making us appreciate the luxury we lived in, abundance of products, freedom, health, and realizing we were taking it for granted. Thank you for stopping us, to make us see how lost we were in the busyness, not having time for the most basic things. Thank you for allowing us to put aside all our problems we thought were so important, and showing us what is actually important. Thank you for stopping the transport. The earth was begging us to look at the pollution for a very long time. We didn't listen. Thank you for all the fear. It has been a global disease for years, but not many of us wanted to face it. And now we have to face it.
I think that's enough, Hani. It gives some clues about that. Thank you.
Thank you. Thank you, Shangul, very much. And really, we took many things for granted, as you have shown in your video, and now we can appreciate them quite well. For the sake of time, I'm going to move to Dr. Sherif Sheta's presentation. Dr. Sherif?
Yes.
Yes.
Okay, the situation in Egypt is somewhat different. I don't know why. Egypt, as you know, is like a country like of 100 million or more. Cairo, the city where I live, is like more than about 25 million people. But the number that given by the Ministry of Health till yesterday, that we have about 900 cases diagnosed as COVID and like 60 deaths. And more than 25% of the deaths are in the age group between 50 and 59. And most of them have comorbidities, or actually all of them have comorbidities, even the younger patients that have asthma or some other health problems. The problem in believing this number that I think that we are not testing everybody. And definitely the issue of transparency, but yeah, I imagine if the test is available, because actually the test is not available. And if you like to do the testing, it's very hard. Even if I have a close contact with a patient of positive COVID, you don't test unless you have symptoms. So, but in the neighborhood where I live, I've seen cases, I've heard about cases nearby living that have COVID, and even cases that died from the disease. So I think dealing with this problem is a worldwide problem, an unanticipated problem. So how can we deal with our patient? I think we are not dealing differently from what Barbara and Shungul have said. We canceled elective appointment, but still we did not close our hospital. My hospital is a private hospital. Also, I'm a teacher in the university. I'm a professor in the university hospital, and the university hospital is not closed. Even the ophthalmology department is still working. But are seeing urgent and emergent conditions like the same mentioned by Shungul, like detachments, endophthalmitis, trauma, acute visual loss, but all other elective procedures are delayed. Actually, the patient themselves ask to be postponed till the picture is more apparent. We are spacing appointments. Actually, when we have more than the appointment spacing can allow, we ask the patient to stay in their cars in the waiting in the parking lot, and then we call them so that we are sure that there are no crowding in the limited spacing area. We have a very good ventilation, sanitizers everywhere. We had a problem with the availability of the sanitizers, and we had in our hospital made a locally made sanitizer. We made the recipe and we prepare it in our hospital because we are running short of these protective instruments. We have wearing protective outfits in dealing with patients, doctors, nurses, and everybody, but activating consultation through telemedicine so that we decrease the contact with the patient as much as we can. What about the hospital measures? We have actually anticipated the problem from the end of January or beginning of February. And we're starting to make an awareness campaign for our staff about how to deal with the patient if things go worse. We have trained staff on CPR so that we can deal with the respiratory problems. We're working actually half power alternatively. So 50% of the workload is staying at home and they come alternatively. And 30% of the administration are also working from home. We measure temperature for everyone at the entry points. We have 3 entry points to our hospital, outpatient, inpatient, and staff entry points. And we have measuring temperatures at every point, and everyone who exceeds 35.5 is not allowed to go in. We have a stay-home policy for every suspect on our staff. So actually, there are 3 of our 250 staff were allowed to stay home because they have just symptoms of flu, and we are not sure because they are not tested. So they asked them to stay like a week at home. We clean all the services around the clock, actually. And we are ready with the ICU beds we have and ventilators, because I think that private hospitals are considered as a strategic backup for the national health system. Like you see here in the elevators, we have signs everywhere. Don't touch the buttons of the elevator with your fingers, just use your elbow. Inside the elevator, we have something that the patient or the visitor can touch the buttons without actually touching the buttons. We space seating, as we have said, in different seating areas. And we measure the temperature for everyone going into the hospital. And the working staff is working, cleaning all surfaces actually around the clock. And we have sanitizers everywhere. We clean the surfaces of the tables, the computers, and the instruments with the sanitizers. And we have sanitizers on the walls everywhere so that everybody during walking in the hospital can clean his hands thoroughly. As Shungul have said, also we have done these protective shields to separate our patients from but we don't have this telescopic way of examining the patients. Financial implication actually is tremendous. We have paying all the payments to our employees. We are 250 employees. Half of them actually come to work and alternatively, but we pay the full salary for everybody. The cash flow in our hospital decreased by like 70% because of the number of surgeries and number of the outpatients are getting much less. We have relatively anticipated this problem since the beginning of the year, and we filled our inventory with masks, gowns, and still we have a backup for 6 months. But the sources of the supplies are limited. We are rescheduling loan. The Central Bank of Egypt have made an initiative to postpone loans for 6 months, so that all our loans are postponed by the government for 6 months. We are negotiating with the suppliers to extend the payment terms, but still now the government is not postponing income tax. We asked for that. They are not cutting down the price of gas and electricity for the hospital. We asked for subsidized loans and subsidized salaries. In some countries in the Middle East, actually the government have subsidized salaries for the private institutes. So there are some questions in our country that's raised. Is that an overestimated and the impact on the economy will be more destructive, or it's actually an underestimated problem? If there is a time frame, the problem with this disease is that we don't have a time frame. We can tell our patients, we can tell our staff, so when this will get over, all our estimations and the economic cost actually not in the steep curve, and hope we will not reach that. And this is intriguing for me. Like in Egypt, it's a very crowded country. In some neighborhoods, the people are so crowded, so social distancing is practically not possible. But still, we have a relatively limited number. If this is because we are not diagnosing and testing everybody, if this is because we are in the beginning of the rise of the curve, I hope not. Or if this is related to the temperature, is it being in the southern part of the hemisphere, a hot country, the temperature may allow us a privilege that not to be infected much like the northern countries. So I think in these periods of doubts, we are all keeping our fingers crossed to cross these tough times. But there are advantages of this crisis, beside those mentioned by the family gathering, the realizing the luxuries we have been living in. I think the government will understand that they will increase the budget for the health sector, because spending money over high skyscrapers or fancy things is not useful nowadays. So if the government have spent an enormous amount of money on the health sector, I think we'll be in a better situation to face this crisis. And thank you, Han.
Thank you very much, Dr. Sharif, for this very nice talk about our current situation in Egypt. And I'm going to postpone questions and discussion to the end so that Tariq would have enough time to present his talk. I know he has a personal experience and encounter with COVID virus patients. So Tariq, please share your presentation with us.
Absolutely. Can you see my presentation?
No, we can see you. You have to share.
Okay, I'm trying to do that. Sorry. Okay, just 1 second. So we do share screen. Okay, share. Does that work?
Yes.
Very good. Okay. So thank you very much, Hani, for giving me this great learning opportunity to learn from my friends and peers. And I'm happy to share with you what we are doing and what our general and personal experience about this unprecedented crisis in the small country of Switzerland of 8 million people. So briefly, you don't hear a lot about the situation of Switzerland in the news, and I will explain why. But we are in an oh my God situation. If you look at the numbers here, you can see that Switzerland is only second to Spain in the number of cases per 1 million. So we are very hard hit. We are extremely hard hit. We go even before Italy in terms of the number of cases per 1 million inhabitants. In terms of cases, as you can see, we're very close to 20,000 cases now, increasing on daily basis, about 1,000 cases per day. And these are the number of daily cases, again, as I said, around 1,000 cases per day. And as you can see here, the numbers are increasing, but we have not seen a huge exponential numbers or the numbers of daily cases increasing exponentially. Naturally, the number of people passing away, a huge tragedy is, as you can see, increasing, close to 600 patients or people actually. Most of those are above 75 years of age. So the vast majority of people that are passing away are in the bracket between 75 and 90. This is the number of active cases actually in Switzerland. And you can see that we might be seeing some light at the end of the tunnel. I'm by nature very optimistic, and I can see some sort of plateauing happening. I'm really hopeful that this will translate into some stabilization in the coming days. Now, of course, when you see those active cases, you can translate them into maybe we are also losing a lot of patients dying, not just having people getting cured, but some other data are very telling. If you can see the 2nd of April data, you can see on the green scale the number of people that have recovered completely and compared to the number of people that have passed away. And the difference is quite dramatic in favor of life and hope. So from my point of view, I keep my finger crossed, and I think we can see some sort of a light at the end of the tunnel. At least I'm looking at that. Now, you've asked me, Hani, about what safety measures that we are doing now in the University of Geneva. Give you a bit about my background or my professional background. I'm a glaucoma specialist working as an academic staff member in and heading the glaucoma department in the University of Geneva. My private practice is also in the University of Geneva. So this also tells you something when I tell you that our safety measures at this point of time is basically to close. We have completely closed the ophthalmology in Geneva. We actually have one secretary now working in the building, taking calls and transferring calls to other secretaries of different staff members to try to manage the situation. Having said so, the good thing about Switzerland and the very good thing about Geneva is that when we met this huge challenge of the COVID-19, we actually decided to face it on as one block. And by one block, I mean the private sector and the public sector. So we organized ourselves that the university hospital is mainly in charge of COVID cases in general, while in some specialties, the workload has been transferred into private practice. One of those specialties has been ophthalmology. So now our colleagues that are privately practicing are taking care of the emergency cases and are with some help from the staff member and the surgeons of the university hospitals, but we are not seeing any of our patients now physically in our premises. And it has been working very well. We are not managing, we are not seeing any downfall into that. Intravitreal injections have been continuing. The emergency cases that are related to ophthalmology have been very well met. I'm very close to the coordination effort, and I can see that so far, so good. And as we say, when a case that is emergency coming, we have a panel of high academic and private practitioners that convene on virtually almost on a daily basis to decide which case has the priority to have an access to an operating room. It is working well. The committee is in unison, and there is I don't see any biases in what cases are getting treatment versus the other. And hopefully, because also we are a city of about 400,000 people with about 70 ophthalmologists so far, we have been able to not fall apart or succumb to this unprecedented situation. Now, my experience as part of all this has also been into looking for innovative solutions. And I immediately figured out that there's no time to recreate the wheel. So it was very important to look at what is available and to use it to the best of our ability. So I found, for example, in my university, an application called HUG at Home or HUG at Home. HUG is the University Hospitals of Geneva. And it was actually an application that was used by nurses to check on elderly patients at their home. It was very easy for us to use this platform, twist it a little bit, and use it for our consultations. Now, I cannot tell you that I am able to look at the fundus using the HUG at Home, but at least being able to speak to my patients, looking into their eyes, managing their stress levels, discussing things with them at one-on-one actually made a tremendous impact, I believe, for my patients and for me as well, because I'm not used to not being able to speak to my patients. Financially, it is a huge crisis, even for a country as rich as Switzerland. Dr. Sharif Sheta, of course, mentioned all the costs and all the overhead costs that we have to manage in our private practices. The Swiss government actually has already launched a program to loan doctors and their private practices, starting from 25,000 francs up to 75,000 francs, and with a very low interest rate that can be repaid over 5 years. This is not something that every country can do, but at this point of time, a lot of my colleagues in private practices are doing that. Me personally, I don't have access to that because my private practice is part of the university. So now our syndicate, the syndicate of academics in the university, is negotiating with the government, because basically as professors in the university, 75% of our income would come from our private practices, and the salary from the university accounts for the rest. So it is a crisis. We are managing it. We are managing it as a country, as a profession, as a family as well. I think I'm giving my children the information that luxuries have to be cut a bit, and yes, we will not beg in the streets tomorrow, but for the time being, we should also consider that we were doing a lot of excesses that have to be managed in a better way for their future as well. Now, from a personal standpoint, personal and professional, I have graduated from the university in 1992, and ever since, more or less, I've been working as an ophthalmologist. And for the first time in my life, I stopped working as an ophthalmologist about 3 weeks ago. Now I run the medical aspect of the 144. The 144 is the emergency service. It's the ambulance service. Now, it's the ambulance service, and under our umbrella, we have 50 ambulances and a helicopter that we use very prudently now. But it is also very important because we are the first line to reply to phone calls from patients. So patients, when they have an emergency, they call the 144. And we immediately went into a situation where the regular emergencies goes into one direction and the COVID-related emergencies go into another direction. Now, when it goes into the direction of the COVID team, which is a team of about 14 doctors and 20 medical students, we can either advise the patient to stay at home and self-isolate, or we advise the patient to go into the hospital, or we send an ambulance, or we send a helicopter to take him to the hospital if needs be. And this is the first line that we have been working on. But we thought that if we are keeping people at home and leaving them there without really medical surveillance, this is really sad. So what we started doing is now we have our team is calling the auto-isolated patients on daily basis to make sure that they are fine, to make sure that they are getting better or getting worse. And if they're getting worse, we can allocate resources to move them. This is a horrendous logistic hurdle that we're trying to climb. And it has been a tremendous personal and professional learning experience for me, learning to try to organize things in a different way than I have ever thought I would be called upon to do. And I have, even as a medical director, have also participated in calling patients with COVID at their homes. And the impact, the psychological impact for the patient of us calling them is huge. But the psychological impact of we calling the patients and hearing them cough and in difficulty is also very, very hard. I have to say, it gives me a lot of nightmares. So again, looking into the resources that we have, I found that the Red Cross, the Swiss Red Cross, has an app called the 5-Up. The 5-Up actually couples patients with healthy people, because we will not be able to follow all those patients as the number increases. So now patients can put on the smartphone the app, 5 up, and they can reach us or reach their buddy, a person that can be a family member or a neighbor, to report a number of times on daily basis that they're doing well. Because on the long run, and for the coming weeks, we will not be able to call everybody on daily basis, and we had to resort to technology. So this has been so far my experience. I am, as a glaucoma specialist, just 2 words for anybody who is handling glaucoma patients. If you are still seeing patients now, make this window count. Any patient that is borderline has to be treated. You can increase medications. You can do an SLT. You have to manage to the best of your expectations, because you will not be able to give an appointment in 1 month time and to check the pressure. So as we are now, if you are seeing a glaucoma patient, manage it as if you are not going to see him for the coming 6 months. And this is realistic. So a long journey, and I'm very much looking for a summer in Egypt. I know that Dr. Sharif Shetta will invite us all on the beautiful north coast of Egypt, and we will sip our drinks and have our watermelons. I am extremely optimistic. Humanity has passed that. We will pass things like this, and we will prevail. And today the sun is shining in Geneva, and I'm sure in a few weeks from now, hopefully not more than a few months, we will have a life that is even better than that we had before. Thank you very much for inviting me.
Thank you very much, Tariq, for this interesting talk, really interesting with the personal input and experience. And before we conclude this, I have a question to Dr. Sharif Shetta, and maybe Shangul can ask it as well. Last month, we have paid full salaries for the employees. What about next month and the following one? Would you consider reducing the salary 50% and keeping your employees, or firing some of them and paying full salary?
You know, this is a tough question, because we are coming to the month of Ramadan, and you know that in the month of Ramadan is the month of people get together. They need some more support, need more money to sponsor their families. So we decided for next 2 months we'll pay the same salaries we have used to pay, irrespective of what happened. But hopefully by this period we'll be out of the tunnel, hopefully, and we'll resume our normal life. But we cannot afford to let them down. And you got it?
Yes. I just missed it for a while. There was a problem with the connection, but anyway, Shangul, would you do the same?
Actually, in Turkey, the government is paying some of the salaries for the employers who cannot pay, who cannot continue to pay. The salaries will be supported by the government.
Well, you are lucky in Turkey.
It is announced like that.
Yeah, you are lucky.
When you apply for that, they will pay like 70% of the salary. So I think this will support all the employers.
Yeah.
Barbara, what will you do after 1 month?
So I think it's very important to promise to the staff that they will keep their job, most of all. So we are doing basically what Shangul is saying. We are using the help from the government, who is paying a partial salary, but to keep the job. And we let them know that this will be true at least for the first 3 months. Then we will have to see. Unfortunately, I work for a big group, so they promised all the staff that they will keep their job.
Okay.
Can I make 2 comments, or we don't have to?
Yes, quickly, in 20 seconds.
Oh, well, first of all, we have to be very careful when we give numbers, because the number of positive people, you know them only if you test them. So we know. And again, the number of death, we know that we should divide that for COVID or that for something else. So we don't know. We really don't know. And I'm curious to know, but it's just a question to all. After changing this way of doing ophthalmology, all these precautions, will we be able to go back to what we did before? Or we will keep using sanitizer, shields, and more precautions anyway, because some of them are really good.
People usually forget, Barbara, and I'm sure that after a while we'll go back to the normal rhythm, and people will forget about sanitizers, and normal life will be regained.
But
It's a balance, constant risk.
One last comment, okay? Shengul, one last comment in 10 seconds.
Yes. I'm sure it will take a lot of time because, you know, the disease will not go away suddenly. So it will take a lot of time, even if it goes to a plateau or to a decremental stage. We have to be careful about our examination. So it will take a long time, I think, to go back to the previous times.
Well, I'll tell you what I think. I think this pandemic will leave a grave impact on our social life. Social distancing will remain for a while and may remain for a longer time. Telemedicine, telebusinesses will boost during the next 5 years. I mean, what we have expected to be launched in 5 or 10 years will be launched next year, probably. I would like what we are doing now, Eva Pharma, Zoom application, and this teleconference for their support. Well, I guess for the sake of time, we have to conclude. RM Solutions, as usual, they are usually so competent and they keep up to the level and keep updated. Thank you, everyone, and see you again soon.
Thank you. Thank you, Dr. Hani. Thank you, everybody. Thank you,
very much.
Pharma, for the great support and the initiation of this type of webinars. I want to tell you that Eva Pharma have been the first company to propose this kind of webinar at international level. I know that everybody is doing it local, but Eva Pharma, really thank you for doing this and their continuous support to the doctors and especially the ophthalmologists everywhere.
Thank you.
Thank you, Muhammad, for being here with us.
Thank you, everybody.
It was a pleasure meeting and a pleasure for everyone. Thank you.
Thank you, dear Professor.
Bye-bye.
Bye.
Thank you. Thank you. Have a good day.